So I am going to turn it over to Amber Wyseth, who is the Director of the Delivery Decisions Initiative at Ariadne Labs.
So what we're going to go over first is covering really who we are as Ariadne, what is TeamBirth, why now, why we're working together, and what this will look like for your hospital. So we'll go through each of these categories. You'll get to meet several members of our team throughout the process. We look forward to spending this hour with you. All right, so first one is, what is Ariadne Labs? So Ariadne Labs is a joint center between Brigham and Women's and Harvard School of Public Health. And we're mostly known for the development of the surgical safety checklist. So for all of you clinicians that have been in an OR, maybe for a C-section, and you go through a checklist, that was something that was developed at Ariadne Labs in coordination with the World Health Organization. Now, the surgical safety checklist has made a huge impact globally and is said to reduce mortality by 30% in every continent across the globe. So big impact. And Ariadne Labs has this vision for health systems to deliver the best possible care for every patient, everywhere, every time. And that emphasis of every patient, every time is something that you're also going to hear with TeamBirth as we get into the project that we're going to be talking about today. The Ariadne team that's here, I'll show you some pictures in just a second, but Ariadne itself is located in Boston, Massachusetts. This here is a map of demonstrating a lot of the work that's done across the globe at Ariadne. So there are 5 main programs that span from birth through surgery, primary care, and also end-of-life care. So there really are these—
Amber,
yes.
Amber, we're not seeing the map. We're still seeing the first slide.
Sorry, there's a delay here.
Okay, gotcha. Want to make sure we switch. Thanks.
Yeah, no, this is the map. Don't worry, I won't read it in detail to you. But I just wanted you to have an understanding that we are going to be working with you. Most of our projects are in the United States, but Ariadne as an organization works globally to implement their solutions in every country, every continent in the world. So the next here is our program. So the Delivery Decisions Initiative is the program that our work comes from. And the Delivery Decisions program is, the main goal here is that we design, we test, and we spread innovations that promote quality, dignity, and equity in childbirth. So our program is all really impacting the time of care which somebody enters the hospital to have a baby and to when they go home. And we also do work within the community because we know that a lot of the adverse events that happen in childbirth aren't just within the health system. So our work does as a portfolio span largely into the community, but this project with TeamBirth, you'll notice, is going to be an inpatient solution. So this next picture here. All right, hopefully that worked this time, Barbara. This is a picture of our team. And as you can see, you're going to meet several of these individuals today as we go through the slides. I told you that Ariadne is in Boston, but our team is currently spread throughout the United States with some of our folks on the West Coast, some more centrally located in Oklahoma, as well as out here on the East Coast. I guess, you know, a result of the pandemic and all of us needing to work remotely. We also have a couple interns, Eden and Claire, so they're on the call today, and you may interact with them as well throughout this process. All right, and here's that snapshot of what I was describing for our portfolio. So today we're really focused on TeamBirth. So if you look in that orange kind of half circle there, TeamBirth is really a solution that is focused on the care team. And the care team, when we describe the care team, it always includes the patient. So this is going to be the nurse that's caring for the patient. It's going to be the physician or midwife, and then it's going to be the patient and their support people. So that's really where this TeamBirth solution is focused. But you can see we have other projects that are really looking at the health system. How do we improve as a system overall? And then you can see we have a couple projects, 3 projects here that are really focused on that intersection between the health system and the community. Always happy to talk more about our work, but again, we're going to focus on TeamBirth today, and you can also read about more of our work on our website. All right, so these statistics, some of them are probably really familiar to you and probably really close to your heart and the mission behind why you're doing the work you're doing, why you're even on this webinar. So these statistics on the left are really focused on outcomes, and the one on the right are really focused on experience, and they're really the foundation of why we're doing what we're doing. So currently today, if you are delivering a baby and you are a Black birthing person, you are 3 to 4 times more likely to die in childbirth. This is a statistic that has really been more notable, or much more talked about, I guess is the right frame, in the past couple of years. But it's not just even that it's this larger picture where we are the only developing country that has worsening maternal mortality. So there's a big problem with our system, and we're definitely trying to see what we can do to make an improvement here. And if you look at the bottom there, it's not just all those individuals that are dying in childbirth, but it's also seeing a really big increase in preventable adverse events or severe maternal morbidity. And I know this is something that Oklahoma and the Perinatal Quality Collaborative cares much about, and you guys have been doing work in. We'll make a connection for you in a few minutes about how TeamBirth can potentially impact these near misses or these morbidity or mortality moments. And if you notice at the bottom of the screen, there's a statistic from the Joint Commission. Around 80 to 90% of these reported sentinel events are rooted in teamwork and communication failures. So you'll see that connection further when we describe some of the tools to you. And so TeamBirth is trying to improve outcomes. We want to save lives. We want to have people come through birth as healthy as possible. But it's also really trying to attend to what we refer to often as dignity or their experience in their birth. So you can see on the right here, this is a national survey of listening to mothers that said 1/3 of women who gave birth in hospitals reported experiencing one or more type of mistreatment. So people are not necessarily feeling valued, respected, and heard during their birth. And secondly, the mistreatment is experienced more frequently by those women of color or those with social, economical, or health challenges. So this is the atmosphere that we find ourselves in, and the one that we're really actively in partnership to try to improve. All right, so what we're going to do is transition over to one of my colleagues who's going to walk through what is TeamBirth, and then we'll explain a little bit of the logic of how we get from these experiences, these near misses, to actually seeing improvements in outcomes and experience through TeamBirth. And then we'll get into what it would look like to partner with us, so you have an idea of if you were to implement TeamBirth at your hospital, what it would look like for you. And then again, like I said, we'll take time at the end to do some questions. So I'm going to pass it to, I believe it's you, Trisha. You're going to start us off, correct?
I'm actually starting off, and then I'll hand it over to Trisha.
Elizabeth.
Thank you, Amber. Well, when our team was designing TeamBirth, we focused on 2 core design principles that we believe are essential to delivering high quality care consistently and reliably for every patient every time. And those are teamwork and simplicity. So TeamBirth enables teamwork by promoting shared decision-making to create psychological safety. And we accomplish this by ensuring everyone in the room, especially the person giving birth, feels permission and opportunity to speak and be heard, and that we are giving the birthing person the information that they need to make a shared decision with their clinical team. And TeamBirth also promotes simplicity by putting methods and tools in place to allow for information to be easily and reliably communicated across the full care team, including the birthing person. So on the next slide, you'll see how by structuring communication, TeamBirth is a simple way of improving care while making it easier, not harder, for clinicians to do their jobs. So the TeamBirth solution aims to provide a structure for effective communication, teamwork, and shared decision-making throughout labor and birth through team huddles and shared visual communication tools. Now, this diagram on the slide is our kind of logic model or causal pathway of how the TeamBirth solution affects behaviors to achieve the desired goals and outcomes. So implementing the TeamBirth intervention with the basic components of team huddles and shared visual tools on the far left leads to the behaviors of improved communication and teamwork. And these behaviors in turn lead to the desired goal of improved outcomes. Those outcomes are improved dignity with more participation by birthing people in their care and more positive experiences, and improved safety with more uncomplicated vaginal deliveries. And as you can see by the arrows, we believe that improving dignity and care will also lead to improved safety and care. But that being said, we hold improving dignity to be a valuable outcome of TeamBirth on its own merit. So with that, I will turn it over to Tricia Short, our implementation specialist, to get into the essential components of TeamBirth.
Okay, so now one component that we're going to focus on is the TeamBirth huddles. The TeamBirth care process innovation is based around regular team huddles that involve the full care team, including the person in labor, their support person, and all the team members the opportunity to speak and participate in shared decision making. You can advance to the next slide. So this just kind of shows the structure and layout of a desired team huddle. It includes first and foremost the patient and their support person, as well as the clinician. So physician, midwife, family practice physician, and then the nurse. They come together either at admission or whenever there is a change, or there's a concern or a change in the care plan, to come together as a team, discuss what is going on, what the preferences are, the background, and then the plan, and they distinguish between mom-baby progress. Once the team huddle is completed, they really anchor that communication on the whiteboard so the patient and their significant other have time to visualize and digest the information that they just received. If you could continue to the next slide. This is one option of a labor and delivery planning board. The huddle conversations are structured by a simple shared visual tool, such as this whiteboard, or it's a shared labor and delivery planning board that ensures the team reliably shares all core information about the care. We do recommend a large wall hung dry erase board, but you may use a different format if it's necessary in your context, such as a dry erase board, a clipboard, or paper. At a minimum, the shared visual tool includes space to note the team, the patient's preferences, care plans, and we're going to be distinguishing those plans for mom, baby, and labor progress. And then the next time the team plans to come together, either as a huddle or as the next assessment. If additional spaces are added, these added spaces must always include information that is accessible and relevant for the entire team. By creating opportunities for these structured conversations to occur and through simple acts such as having the names of all team members, including the birthing person and any support people or family members, written on the whiteboard, we also create a safe space for shared decision-making and participation from all care team members. In addition to the whiteboard and huddling, there are two additional labor support tools called the Admission Discussion Guide and the Assisted Delivery Discussion Guide. These are both patient-facing tools that are utilized primarily in the Admission Discussion Guide and OB Triage. On the back of each one is the Labor Support Guide, and it just provides patients with options of what they can do to help support their labor progress versus what the clinical team can do if interventions are necessary to support them. So the Admission Discussion Guide and OB Triage is a patient-facing tool to help the patient really understand if the provider is recommending either discharge to home or perhaps just movement, but not yet admission over into labor and delivery, but wants them to stay close because active labor is near. It just provides information as to how to articulate and educate the patient in that way. The Assisted Delivery Discussion Guide, it does provide the minimum requirements, ACOG requirements for a cesarean section for first-time mom. And so again, this tool, the idea is you bring it out or they're educated on it from the point of admission. And then whenever there is a moment or the time comes that perhaps the mom is not progressing, we've been pushing for multiple hours without progress, and it's time to do a C-section, you're really validating the reason for it and educating the patient as to why it's necessary. These tools are very valuable and the patients are very grateful to have something that they can hear what is being said, read what is being said, and just affirm the team's recommendation. And on that note, I will be handing it over to Amanda.
Great, thank you, Tricia. So I'm going to talk briefly about the pilot trial that we did from 2018 to 2019, where we actually tested TeamBirth's ability to improved communication and teamwork among 4 hospitals that were on both coasts of the US. So we've got South Shore Hospital over in Boston, 2 hospitals in Washington State, and then also in Tulsa, Oklahoma. And we are going to look at some of the findings. Perfect. I was about to say next slide. So we asked clinicians after they experienced the TeamBirth implementation if they would recommend this project and how they felt about the project improving care. And we also asked them, does this project clarify non-urgent cesarean decision-making ability? And you can see overwhelmingly folks said that 90% said that they would definitely or probably recommend this project. 94% believe that the project would improve care. And 88% believe that the project helped clarify that decision-making for non-urgent cesarean deliveries. And if we go to the next slide, we also interviewed clinicians to hear them and hear their perspectives about TeamBirth and how they felt it was impacting the quality of care at their hospital. So I won't read through all of the statements here, but just to pick out a few quotes here. The last one, which was a midwife at one of the hospitals, had said the overarching goal is really encouraging knowledge and improving families' understanding and empowerment of their own bodies and the processes that they went through and how that happened. And then they bring it back to that should be the goal of our whole system. And then in thinking about patients, we'll go to this next slide here, where we asked patients, did you have the role that you wanted in making decisions about your own labor? We also asked them, did the doctor, midwife, nurse, the care team talk about your labor in a way that you can understand? And then did you feel like sharing your preferences actually made a difference in the care that you received? And here you can also see the overwhelming dark blue and the light blue here, where folks definitely or somewhat agreed that they were able to achieve these things here. You'll also notice that there was a statistically significant relationship between the number of huddles and the patient experience, which is suggestive of a dose response. With more huddles, higher patient experience. And then if we go to the next slide, we have a few quotes from patients about how they felt TeamBirth had an impact on their own experience. So again, I'll hold this slide here, but I'll call out some of the things on this slide that really speak to TeamBirth. This last quote here, which was by a nurse, says, I think it's been really empowering to the patient to feel like they do have a voice and they can use that voice in communicating what they want. And I will pass it over now to my colleague, Amani Bright, who will talk about some of our current work in Tulsa.
Hi, everyone. So Hillcrest and OSU are the 2 sites where we've been working with their implementation team to implement TeamBirth in both the labor and delivery unit as well as the postpartum unit. We've launched this spring and we really have been able to work with their teams in moving implementation forward and hopefully being able to see some change.
Okay, so I believe we're handing it over to you, Barbara, you and your team to go through some of the data as to why we're working on this project together. And just tell me next slide when you're ready for me to advance.
Great, thanks, Amber. So, you may be asking, well, why are we doing this? Well, first, we can look at the data. And we do know that our C-section rates, and I'm sure most, if not all of you all are familiar with this, have been increasing. And really the one that we're trying to impact the most is that NTSV C-section rate, the nulliparous term, singleton vertex, basically low risk first-time moms. And we can see how their C-section rates have also been rising along with the total rate. And that, there was a little bit of a decrease, but now it looks like it's on the rise again. In the box at the bottom, you can see that the Oklahoma total rate is 32.1. That's the 16th highest in the United States compared to the US rate of 31.7. And then our NTSV rate in Oklahoma is a little bit less than the United States rate. These are final data from 2019 of 24.5% compared to 25.6%. So looking at the next slide, when we ask what can we do to decrease these rates, and this is one of the most, the statistics in healthcare that has extremely high variability. Some hospitals of the maybe as low as below 10%, and other hospitals in the US are greater than 70% for C-section rates. So how can we reduce this variation? With data collection and measurement of maternity care quality. So you all may be providing some data to, for example, the Joint Commission, and then Medicaid policy. Well, now that we have expanded Medicaid in Oklahoma, and we have looked at how can perhaps Medicaid influence hospitals to improve their care practices. And really this third one talks about patient-centered decision-making through public reporting, where this will become, we anticipate this will happen in the next few years. You all see Hospital Compare currently includes our PCO1 rates or the early elective deliveries rates. We anticipate that soon they will begin reporting the NTSV rate as well. And then what are these supported birth professionals with doulas and the labor and delivery support, one-on-one support, which has been found to reduce C-section rates. And really the communication that's involved here with the patient is key. So looking at our next slide, at some Oklahoma data. We also in Oklahoma are working on our rates of severe maternal morbidity. This is data from the AIM data portal provided by the Oklahoma State Department of Health. And what we focused on in the past is the severe maternal morbidity, reducing that related to care practices, formal care practices related to hemorrhage and hypertension. We see here our rates have decreased since we began this work from in 2011 up to approximately 1,000 or about 1,300 women per year who experience severe maternal morbidity, down to almost a 50% decrease to about 728 women per year. And then at the next slide, this just breaks this down by quarter. And you can see that when we launched AIM, we have seen a decrease of our severe maternal morbidity rate of 23% overall. So this is encouraging news. But when we look at the next slide, we also want to consider maternal mortality and how this has decreased we can see that our rate is starting to decrease as we have begun the implementation of these maternal safety bundles, and hopefully we can see this continue to improve. These care practices that we've done so far have, again, focused on the guidelines for care and implementing safety bundles. And we know, at the hospital, you can do those things, but it only affects outcomes so much. And one of the things we see with communication errors that has been studied so much over the last 20 years is that, the majority of adverse events include communication issues. And all of the work that's been done so far to impact these communication issues, for example, Team Steps developed by the Agency for Healthcare Research and Quality, where you may have heard the terminology of huddles before, it didn't include the patient. So this, I believe, is very key, that we are including the patient and the birthing person's support persons and family in this process. So what we hear anecdotally is patients feel like instead of things being done to them, they're being done with them. And that It does improve our transparency and accountability, and we believe that this will really improve the culture in our labor units and other units that hospitals that have begun implementing TeamBirth, such as Hillcrest and OSU Medical Center, are really expanding this because they feel it's so valuable to their postpartum units and their NICU and prenatal care. So looking at our next slide, we mentioned the disparities in care as well, and that those with the poorest outcomes, with the disparate outcomes, are likely to be impacted the most with these communication improvements. So these are some of the data that show us why we're doing what we do. If we look at the next slide, we want to make sure though that we remember always that each of those data points is representative of a person, a patient, a birthing person, a family member, and that is something that we at OPQIC want to keep in the forefront. So I'm going to let Sarah Johnson, our patient partner, talk about some of the voices from Oklahoma that have vocalized and shared some quotes with us on how TeamBirth would have affected their labor experience.
Thanks, Barbara. So I'm Sarah Johnson with the Maternal. I'm the Maternal Perinatal Navigator at OPQIC. Many of you know me and have heard me share my story, but another part of my work is to convene a patient partner network of women who have had complicated birth experiences. So this group helps to bring a patient perspective to our work at OPQIC. And naturally, we have had several discussions with these patient partners about the TeamBirth project and if or how this model of communication would have impacted their birth experiences. So here are a couple of the comments that we have heard from these discussions. And as you can see, I'm just going to read them. Including me and my family in communication during labor would have eliminated so many questions that I still have about what the team did or didn't do to help me. And I would have had confidence to ask for more testing, and maybe the multiple doctors working on my case would have worked more collaboratively with me and together to get an effective plan in place. So as we saw already in the previous slides, patient surveys are showing that TeamBirth will help to improve patient perspectives. And I'll speak for our Oklahoma patient partners when I say that we all believe that if TeamBirth had been in place during our deliveries, our experiences would have been much more positive, even if the outcomes had been the same. We all felt that a lack of inclusive communication negatively impacted our birth experiences. So thank you, Barbara.
And another thing, Sarah, another reason why is that you all may have heard that Oklahoma received 2 years ago through the Health Research and Services Administration of the Federal Department of Health and Human Services. They went into a collaborative agreement called the State Maternal Health Innovation Program. So the Oklahoma State Department of Health has received funding through this program. And through this funding, we are supporting our partnership with Ariadne Labs to make Oklahoma the first state in the nation that would incorporate TeamBirth into all of our birthing hospitals. So we thank them for the support. And I'm going to now turn this back over to the Ariadne team to talk a little bit more about how this will look moving forward in Oklahoma.
So I'm going to pick back up here to discuss what TeamBirth will look like at your facility. And I did want to go ahead and address one of the questions that was in the chat because we do recognize that each unit or each hospital facility has a wide variety of resources. So some have residency programs as well as OB hospitalists, others may not. TeamBirth can still be incorporated so long as you have a phone, and that was trialed in the pilot phases both at St. Francis as well as the other 3 facilities, 1 in Boston and 2 in Seattle. Just so long as when the team does come together, we're taking that conversation and those communication key points from the nurse's station where they would typically be held previously to the patient's bedside. So whatever tools necessary to help make that happen, whether it be a speakerphone, a telephone, or if you have access to the providers that are on the unit, then that would be how we would encourage to incorporate them. So when we talk about implementation or implementing TeamBirth, we follow this implementation pathway. It's structured as a circle because we understand that change is never linear and that we may need to move back and forth throughout the implementation pathway. The 4 phases of implementation are broken down as follows. During the prepare phase, you're going to build your implementation, build support for TeamBirth as you socialize it, and then build your implementation and measurement strategies. Next, you're going to begin to engage and coach. During this phase, you will train champions, test and adapt TeamBirth, train staff and providers, and launch the intervention. Third, implement. So at this point, your team will come together to implement TeamBirth, collect data and feedback from patients and clinicians, and continue to engage resistant stakeholders and begin to build for sustainability. And then 4th is the sustain. This is a continuous ongoing measurement and integrates TeamBirth into your organization's learning management system. And really, at this point, it changes the culture of your unit. So to discuss the timeline and those components, I'm going to hand it back over to Barbara.
This is our proposed timeline as we work through. You guys have received the email for invitation. We sent it to different nursing and medical leaders at the hospitals, at some of the hospitals in Oklahoma. This was also sent to the CEOs and other leadership, quality leaders at your hospitals by the Oklahoma Hospital Association, who's one of our partners in this work. So we here are having an informational webinar for you to gain more knowledge about this. And again, we're happy to answer any questions today or following up. If you have any questions, feel free to share them with us. We have a deadline in August for you to submit your commitment letter, so we'll know who is going to be participating in TeamBirth. And I think the deadline for that, I forgot to look it up, was August 9th. If somebody can confirm that and put it in the chat, so that you will be committed. If you already know that you intend to commit, you can go to our website and go back to that email. I'm happy to resend and complete the intent to commit information, so we'll kind of have an idea of August 2nd. Sorry about that. Thanks, Denise, as to who is actually intending to commit, and then you would send your information by the end of July, the beginning of August, August 2nd. We will have an IRB process for those of you all who are interested in participating in the research component of this, and we're going to talk about that more in a minute. Through September through January, we will have monthly webinars and then more frequent coaching calls with your hospital team. This is all very familiar to what we've done with other QI initiatives, and then especially OMNO. For those of you all participating, you would understand the coaching calls that we're having. This really helps to keep you on task, and we'll talk about different subjects here about how you're preparing and what you need to do so that we'll be able to launch then in February or March of 2022. Beginning then and moving through June, those will be really the launch time period where we'll have monthly or more frequent, we'll have monthly webinars and more frequent coaching calls with your teams, again, to talk about how things are going at your place and what we can do to help, learning from others in the webinars, getting your whole team together on the coaching calls so that it really ensures that everyone is staying on task. And then from July on, we will have less frequent coaching calls, but we are here to help you and again, keep you moving through the process of implementation. Like I said, many of our hospitals have decided to scale this up through all of their units and into prenatal care so that the birthing people, the patients, their families that this is the model of care and communication throughout the entire process. So this is the basic timeline and what we'll be doing as we move forward. I'm going to turn it back over to Ariadne.
Okay, so for our IRB reliance options, there are 2 routes that we can go. The first one is Smart IRB, which is a platform that offers an IRB reliance agreement and a web-based system that provides a central process for sites and their investigators to request, track, document any study-specific reliance agreements. The sign-up process is quite simple, if not already. I think there's 5 steps, and we have an IRB specialist that is willing to help in any way if that's the route you choose to go. The second one is an IAA agreement, and that calls for a bit more coordination between both sites because there's no central platform to make those changes. It's not necessarily more difficult, it just takes longer to complete and finalize. But we will be following up about Smart IRB and the different reliance options in the weeks to come.
Thanks, Amani. And before we go into next steps, I do want to just touch on the research component because maybe research is familiar to you guys in your hospitals and maybe it's brand new. We do want to really encourage you to think about participating in it, and it's for a couple reasons. One, we know through all of our implementations, which, we talked about our pilot trial, but at the end of this year, TeamBirth will be implemented in 23 hospitals in the United States. So we're getting a lot more feedback around what it's like to implement TeamBirth. And one consistent theme that has been in every implementation we've done is the importance and feedback to support implementation. So we have been surveying patients and really hearing about their experience and wanting to see if we can make measurable change in their experience by doing TeamBirth. That data is really powerful to feed back to your staff. And so one of the questions submitted to us was around resistors, which we'll talk more about when we get to Q&A, but data is really, really powerful in moving an initiative like this forward and really creating that culture change that Tricia referred to. The other thing is this is a really amazing opportunity as a whole state to be measuring the experience of the people that are birthing in your hospitals. We know, like Barbara showed, a lot of the outcomes and the improvements that are being made, but we know a lot less about what those individuals feel like about their care and how they're experiencing their births. So it's an amazing opportunity for the whole state to be involved in the research. We do have a lot of IRB supports on our team. Amani does a lot of she's our reliance expert, but we're more than happy to set up a call with you to talk with you about it, answer any questions, and just don't want research to be scary. We really want it to be approachable and a really cool opportunity for your hospitals. So more to come on that, but happy to have follow-up conversations. All right, on to next steps. Go ahead, Barbara.
So I mentioned the quick intent to commit form online, and I can have one of my team members put that in the chat if you want to have easy access. Signing the hospital commitment letter and returning that by August 2nd. We will send a follow-up email after the webinars and include all of this information in that email as well. Think about who your team members are. Recruiting team members, a physician champion. We'll talk more about this, a nurse champion and things like that, who will be involved in your process. We will, once we receive your letter of commitment, we'll be sending you a hospital information survey to get some basic information about your hospital, and then looking into identifying the IRB contacts and beginning this reliance process. And again, I would emphasize what Amber said about getting the patient voice. I've been participating in the calls with Hillcrest and OSU Medical Center, and the patient feedback is so powerful, and the responses, they have a very high response rate, and I think a lot of that is because patients really like this and they want to provide their feedback. I'm just saying this anecdotally. But even one of our responses from one of the hospitals talked about how a woman who had given birth a few times earlier and had had some traumatic experiences. And she compared how different this was with this experience and with TeamBirth. And she said, really, TeamBirth has allowed me to begin to heal. So I think that these things are really powerful, and really there's no reason why we wouldn't do this. And we're happy to help you. We will be having another call then Wednesday if you have other team members that you want to encourage to attend the webinar. And then in August, we will see below you have the schedule for the planning sessions for your team to attend the webinar, where we'll talk more in detail about what we're going to do as we implement this process. And there's the link at the bottom to register in those planning sessions. So that's what you can expect for next steps. Yes, we will give you the slides in our follow-up email that feel free to share as you need to. And please reach out to us if you have any further questions.
So I'm going to talk very quickly about ARIA, which is our online community of practice. This is what we use to support the implementation of TeamBirth. So ARIA provides tools and resources to those who want to implement. We have one free version that you can sign up for today, and we have a second version that can be used if you are wanting to implement TeamBirth, and you receive further resources and tools at no cost with that version. So I'm going to put the link in the chat to ARIA, and next I think we are moving on to Q&A.
A couple of the questions that we received along with the registration, we just put on the slide, but I got rid of the slide, so I'll read it to you. The first one here is the training for TeamBirth an LDR only, or the entire maternal child team? So what we recommend for TeamBirth implementation is that everyone needs to be trained that participates in direct patient care. So what that looks like on your unit is going to be anybody who's doing direct care for labor and delivery, and then anyone who's doing it in postpartum. So mostly that's looking like your obstetricians, if you have midwives, your family practice, your nursing staff, and then in postpartum, you're going to add the additional pediatricians. There's going to be other team members who occasionally may be a part of a huddle. That might be like an anesthesiologist for a really high-risk patient, respiratory therapist, a lactation consultant, etc. Those team members need to have exposure to TeamBirth, but do not need to have direct, like hands-on scenario training to what it looks like. So I hope that gives you a better idea of kind of all the team members you need to be thinking about, especially about who's on your implementation team and which individuals may be able to serve as a champion. So the other one says, what can we expect for results for implementing TeamBirth if the doctors are not on board with it? Well, that's a really good question. And I would say that, I guess I have a couple thoughts on that. One, with every quality improvement project, as you guys know, because I assume your leads of quality improvement is why you're on this call, you know there are always resistors. And this can be resistors with physicians, nurses, it can be anybody. And so you will have resistors to TeamBirth that will be present. However, what we're doing with TeamBirth is a little bit sneaky in the sense that the behaviors are behaviors that you should be doing or that are familiar. right? You talk to your patients, you come up with a plan of care when they're in labor or when they're in postpartum. You talk about when you're going to do a next assessment. The challenge is, as clinicians, we don't communicate reliably every single time. We leave stuff out at 3 a.m. when you've been on call all night long. You're not doing your best job. You're not your best at communicating. And what TeamBirth does is it provides a structure for you as the clinician to show up your best self every time and to make sure that information is all transparent, which really includes the patient into the process. So why I'm telling you that is because when you talk about TeamBirth, you may have some resistors, but there's not that much to resist to, because it should be stuff that's happening anyway. The part that you may experience a little bit more resistance to is maybe using the shared planning board, and sometimes over speakerphone, which we have lots of implementation guidance on how to do that. And at everywhere we've implemented it, people have been nervous to try the speakerphone, but then it's been no big deal and has really transitioned into standard practice going forward. And those are some of the things that we will go in depth with when we are engaging with you on the webinars, as well as in the coaching calls, so that you have the tools how to understand how TeamBirth would operate in your context, as well as what are the adaptations or support mechanisms that you would need to add in to make it successful. So I hope I touched on that briefly. I don't know, Tricia, is there anything else you would want to add before we open it up to more questions?
No, I mean, I think that was a phenomenal explanation. The only thing I might add, having implemented this at my previous facility, St. Francis in Tulsa, Oklahoma, we did have resistors. However, as we started utilizing this communication technique and style, patients raved about their experience. And so what we found is that providers who were maybe not as on board would see these patients at their 2 to 6 week follow-up appointment. The patient would talk about how different of an experience they had and how pleasant of the experience. And then we had providers come back and say, okay, let's re-engage with what my understanding is with what we should be doing. It's clearly making an impact and a difference. And that helps bring them along. So the patient feedback for the providers, as well as the nursing staff, is really valuable.
Thanks, Tricia. So we got another question in the chat around how does this work for adoption cases? So the board itself is not necessarily limited to, a birth where the individual has custody or is keeping their child. It can be used in adoption cases. It also can be used in demise births or other different circumstances, because what's really going on the board is not like everybody's transparent medical record. Like, that's not the information that goes on the board. What goes on the board are the names. So who all is a part of that care team, the preferences. So you can have preferences. I would hope that preferences would be discussed for adoption or demise or any other extenuating circumstances. So important for everybody to be on the same page around that. And then the plan for mom, baby in progress are still relevant. We still have to labor somebody, get them delivered. And so mom and baby are baby's pretty straightforward on what the plan is for there. And then progress is really around what are we doing for the cervix and the uterus. And the mom is what are we doing for that whole person who is here in labor. So that can be a really good time to support any of those other circumstances that are really notable for the team. And the next assessment is still really relevant. So, if there's a reason your team is, concerned about using a board in a certain case, it doesn't have to be used, but we've implemented again in lots of hospitals and don't really see a reason why it can't be used for every patient every time.
With the huddles, it was mentioned, if the provider can't be present, if a clinician team member cannot be physically present, they can be present via the telephone. And what providers have seen too is that, this sounds like they'd be getting more interruptions, but because of the formatting of the whiteboard where it talks about next steps and what to expect, what they've found anecdotally is that it really decreases a lot of that, because when you have the huddle and the information on the whiteboard is what's happening next. And so everyone has that shared mental model of what is the plan here. So as a nurse, it's not like, oh, we forgot to ask that, and you're going back and calling and doing all this back and forth. it happens all together and we get the next steps, and it's just becomes a more efficient way of communicating. Instead of a lot of back and forth between the nurse, the doctor, and the patient, it's everybody coming together at the same time. So what it really does is force everyone to become a good communicator. I know that you all have worked with lots of team members, and some people are excellent communicators. This will make them even better. And for those who are not the best communicators, this also makes them better. And really including the patient and making sure they're at the center of everything, just to me is the key piece of this. So wanted to address that it really does not involve, like Amber said, it's what you're already doing, and it just makes it a more efficient and transparent process.